Welcome, everyone. First, I'm going to give a little overview of MOC. So the Michigan Opioid Collaborative is an interdisciplinary team supporting providers and communities to increase access to office-based addiction treatment, expand care, and improve quality of care with patients with opioid and other substance use disorders in Michigan. MOC is grant funded through Blue Cross Blue Shield and the Michigan Department of Health and Human Services. We offer free same-day consultation services to help provide evidence-based quality addiction treatment. Our team of specialists are available to help with patient case questions related to treatment and management of substance use disorders. MOC offers quarterly introduction to buprenorphine trainings, as well as webinars on a variety of educational topics, including addiction, stigma, and substance use topics. We also have a hepatologist on our team who offers Hep C treatment consultation within 48 hours, facilitates a biweekly case consultation webinar to review cases with providers, and has developed a 3-part webinar series on HCV treatment. We have created toolkits for providers to have more resources when treating patients with multiple SUDs. Okay, so next I'd like to introduce our 2 presenters for today, Paul Trowbridge and Shiva Sethi, who are both with Michigan Opioid Collaborative. Paul Trowbridge completed his medical school training at the Wayne State University School of Medicine. He subsequently went to Brown University for his internal medicine internship and residency. He currently practices clinical addiction medicine at Trinity Health in Grand Rapids and works on the Michigan Health Endowment Fund's Hospital Engagement Addiction Resources Team Initiative, which looks to expand access to addiction services for hospitalized patients. He's passionate about expanding access to evidence-based care for people with substance use disorder, particularly in rural communities. And Shiva Sethi attended Drexel University College of Medicine and has completed her residency at Montefiore Primary Care and Social Medicine Program in the Bronx, New York. Dr. Sethi currently works as an addiction medicine physician with the Michigan Opioid Collaborative and sees patients via telehealth at Bright Heart Health.
Fabulous. So welcome to the second part of our series on prescribing HIV prophylaxis. And let's make this less complicated. This is super easy. So we're going to talk through how to start PrEP. Shiva Sethi and I have been working on this for a while, and Jesse also helped us put this particular presentation together. So thanks to both of them as well. I don't have any disclosures. To recap, this is the second part of the series Dr. Sethi previously talked about, and we previously learned why taking a sexual history is important in many regards. Specifically, we learned who's at risk for HIV and how to take good sexual history. The prior lecture should be or will be soon posted on the Michigan Opioid Collaborative's YouTube channel as listed below. But we're going to we explored those things already. And this one, we're going to walk through kind of what to do after taking a sexual history, how to prescribe HIV prophylaxis as it is appropriate. So we're hoping to identify indications to start HIV prophylaxis, be able to list the important labs to check before starting PrEP, list common side effects for PrEP, be able to list appropriate follow-up testing after starting PrEP, and know when to stop PrEP. So kind of the whole life cycle of HIV prophylaxis from start to finish there. Part of the reason we're focusing on the medications is we came into this project thinking it was the kind of uncomfortable conversations that people were holding up people from prescribing, which is true, as you can see in there. But when we did some informal polling of the Michigan Opioid Collaborative's roundtable discussions, what you guys told us was that it was really people were uncomfortable with medications. So we wanted to put a little bit of focus on that to do that. And this is really understandable why we'd be uncomfortable with HIV medications, because we often think of the bad old days of things like AZT and nevirapine and these medications. These medications used to be really scary. They used to be really toxic. They used to be something that really only a specialist should or could handle, someone who had specific training in this. And we get to sit back and relax now. I'm young / old enough to have clipped the end of the old scary days, and we're not anywhere near where we were. We just have a lot of historic baggage. These medications are super easy. It is roses and unicorns out there right now with the HIV medications. How easy is it? It's almost too easy. Indeed, it might be easy like Sunday morning. Um, so this we can relax. This is an easy thing. This is a lot easier than a lot of what we do in primary care. So we're going to walk through and try to make it less scary for people. I'm going to put a brand name alert on this. For the purposes of this talk, I will primarily be using brand names, and everyone knows you're not supposed to do that in a professional, unbiased presentation. However, I'm going to. Why? Because really, in HIV geeks, we get really into the 3-digit labels for HIV medications. We can rattle off our combo meds. Turns out that's intimidating for most people. Patients don't come in saying they want to be on TDF. They come in saying they want to be on Descovy. They don't know what TAF is, nor do most doctors. So I'm going to stick to brand names for ease of understanding. I will list out the generics, and none of the companies are paying me to say anything. It's just ease of use here. Some abbreviations that will show up in later slides, and we should know what they mean. MSM is men who have sex with men. TGW is transgendered women or biologic men, which is important for categorizing who we can use medications for. And people who inject drugs is PWID. This is the source document for most of the recommendations. I'm going to keep it pretty simple, but there's a lot of useful information in this. It is 108 pages, and none of that space is wasted. It has a lot of useful information in this, these recommendations. This is everything you need to know. If you learn nothing else from this presentation, this is it. In fact, most of it, us can just focus on that first table. The second table is for injectable PrEP. First table is oral PrEP, which is easy, but let's wade in. Here's your reference slide, though. If you need to go back and check anything, all of the information is essentially on this slide. Well, so let's quickly define what PrEP is. For many of us in healthcare, we're familiar with PEP. PEP is what you get if you have a needle stick, or outside of healthcare, if you've had a risky sexual exposure. It's prevention after you've been exposed to HIV. PrEP is prevention before you're exposed to HIV for people who are at risk for it. It's been repeatedly shown to decrease the risk of HIV acquisition in high-risk individuals. There's a 99% reduction in transmission from sexual exposure if you're taking PrEP regularly, and at least a 74% reduction in transmission via shared injection equipment. And that's an understudied group of people, so it might actually be better than that. We know that PrEP is very underutilized. It only protects against HIV and not other sexually transmitted infections or injection drug-related infections. And very importantly, and I'm going to circle back to this a whole bunch, it is not a complete HIV treatment regimen. It is less medications than you would use to treat full-on HIV, which is an important point that we'll talk about a bit. Who's at risk for HIV exposure? Well, people who inject drugs and people who have sex. We consider these people for preventative HIV medications. We previously had these really complicated risk tables where you had to make these calculations, but the CDC really simplified things considerably. It's these two groups of people. Is everyone in these groups of people at risk for HIV? Well, potentially yes. Should everyone be on PrEP? No. It's a matter of degrees of risk. Take myself. I'm married, monogamous, in a long-term relationship. Is it possible that I could require HIV? Sure, the world's a weird place. Is it likely? No, I wouldn't be on a medication to prevent something that I'm incredibly unlikely to get. However, the CDC made some changes with the 2021 recommendations, and they do recommend that all sexually active adults and adolescents should have PrEP discussed. I would add, in my personal opinion, though it's not guidelines, that all people who inject substances should also have that discussion. PrEP is for those who are in a higher risk group as defined in this chart, which is pretty straightforward. There's not that many categories. There's a couple points to highlight. For sexually active adults and adolescents, it's anyone who's had vaginal or anal sex in the last 6 months. Oral sex does not qualify as a high-risk behavior. Put that out there. And has one of the following: an HIV positive sexual partner, a bacterial sexually transmitted infection in the last 6 months, because if you got chlamydia, it could have been HIV. It's an indicator of not knowing what your partner has and not consistently using condoms, or a history of inconsistent or no condom use. This part is really because if someone is virally suppressed on HIV, we now say undetectable is untransmittable. So if someone has an HIV positive partner, they're having sex with them in the last 6 months, but their partner doesn't have a detectable viral load, that's not a risk factor for acquiring HIV, because the risk is so low if they're virally suppressed. Amongst people who inject drugs, if they have an HIV positive partner that they inject with, that's not the case. We don't say that the risk, even if their partner is entirely suppressed with their virus, and they're using injection equipment with them, we would not say that they were not without risk. People who use shared injection equipment can potentially still pass along HIV. We just don't know. We haven't studied it well enough. And we say shared injection equipment purposely, not needles, because it's really anything that's involved in the injection process that touches a bodily fluid. So it's cookers, it's cottons, it's syringes, even snorting and smoking implementations can pass along hepatitis C and likely HIV. So pertinent history. Looking at the sexual side of things, the vast majority of HIV is spread sexually in this country. CDC recommends a brief sexual history in all patients. Now, I love taking a good sexual history, and Dr. Sethi already gave a fantastic lecture on this. But for our purposes, just to establish the indications for PrEP, we don't actually need that much information. Your standard conversations about STIs are probably going to give you all the details you need. What do we need? It's all in this chart, and essentially boils down to, do you have sex with men, women, or both, which I actually don't think is that impertinent, but CDC still thinks so, as men who have sex with men are higher risk for HIV. Do you know what your partner's HIV status is? Do you always use condoms? And have you had a STI? If you've had an STI, again, it's a marker for not consistently using barrier protection. And if you picked up an STI, it could have come with HIV as well. It means you don't know where your what your partner has. And notably, STIs include pregnancy. Life is a 100% fatal sexually transmitted infection. It's also an indicator of were you using condoms consistently? So important to consider that as well. What about drugs? Even easier. And I'm going to modify this slide slightly. I would take off the word drugs. Anyone who injects, a lot of people might not consider what they're injecting to be a drug, such as a transgendered individual self-administering non-prescribed hormones, or people who inject illicit steroids for bodybuilding purposes. A lot of people wouldn't consider these drugs in the commonly known sense, so I would make that addendum there. But it's really straightforward. Do you inject any substances, and have you shared any equipment? That's it. You have your indications if they have shared equipment right there. So it's really kind of straightforward. Further history can and should be taken for most purposes of doing a sexual history. But for getting that indication for PrEP, we don't need that much information. It's really straightforward. So now we know if someone has an indication for PrEP, what's next? And here I'm going to throw in a little background, because otherwise it's just brute memorization of which regimens are for which people. It's contextualist memorization. There's really only 3 regimens, but why struggle to remember those when you can understand why we're doing the things we do? First, we have some biases in the research. The largest group at risk for HIV in the United States is by far and away men who have sex with men. Therefore, much of the research around this medication, these medications have been done with this group in mind, which is translated into some of the approved regimens only being approved for this group. And for study purposes, we're lumping transgendered women, or people who are biologically male, into the same group as men who have sex with men. So currently self-identified women who are born as men are lumped into this group. There's also some biologic differences between the sexes, primarily between rectal tissue and secretions and vaginal/cervical tissue and secretions. Typically, anal sex we identify as a riskier sexual behavior. It's just easier to cause tears in the anal mucosa than vaginal mucosa. It's more easily injured, so it's more likely for you to pick up sexually transmitted infections. However, because of the pharmacodynamics of antiretrovirals and those secretions, it actually takes longer to build up to a therapeutic level in women, which essentially means that off-label uses of non-daily regimens are not recommended in women because they can't get reliable protection without regularly taking these medications. And we're going to talk a little bit about those off-label uses coming up. Again, for research and guideline purposes, biologic males are all lumped together as transgendered women and by other men. And then pharmacodynamically, it doesn't matter what group you fall into if you're injecting. The pharmacodynamics are all the same. You need it built up into your system. The same doesn't matter if you're man, woman, or transgendered individual. So here's our approved regimens with all their generic names, letters, and their brand names there: Truvada, Descovy, and Apretude. Things that might jump out from this list. That last one there, what is it? It was approved in December of 2021 for HIV prophylaxis. It's an integrase inhibitor very closely related to dolutegravir, which has a very high barrier of to gaining resistance from HIV. It has been shown to be equally, or if not potentially more efficacious than the oral regimens because you don't have to worry about adherence as much because it's in your system, whether you want to be or not after the injection. It does come with some other issues like the tail, which remains as it remains in someone's system for a very long time and very gradually decreases after that. We will talk a little bit about that. The other thing that might stand out from this list is the first two options look a lot alike because they're a lot alike, and we're going to talk about that a little bit. Again, for ease of use and familiarity, I'm going to primarily stick to the brand names, but here's the medications with all the identifiers you could possibly want on them. So Truvada and Descovy, tenofovir L-indemnifate, or tenofovir disoproxil versus tenofovir L-indemnifamide. They're very similar. What's the differences? Tenofovir L-indemnifamide is the prodrug of tenofovir disoproxil. So Descovy, the tenofovir in there actually breaks down into the same product that's in Truvada. It just doesn't start that way in a human body. It has to be processed inside the cell before it can do that. What does that mean practically? It gets higher levels inside the cells, even though less of it gets into a human body to begin with. We can give it at lower doses than we can give Truvada. So it's 10 to 25 milligrams versus 300 milligrams of tenofovir in Truvada. This means there's less risk from tenofovir side effects because it's not in the body nearly as much, even though it's getting actually better levels inside the cells where it needs to be. So things like decreased bone mineral density, renal toxicity aren't things we need to monitor for nearly as much with this medication. This medication has always only been studied really in biologic men, so it is not currently approved for use in women, though I know a lot of people will do that anyway because it's just an easier medication. Here's all the regimens and the way they work and how we use them. We have our Truvada on top. That is always your go-to answer. And we're going to emphasize that again and again. It's approved for everyone. So it's available in 200 milligrams of emtricitabine and 300 milligrams of tenofovir disoproxil one time daily. This is the only one where we have studies really approved for alternative dosing in some men, and it is approved for everyone greater than 35 kilograms or around 80 pounds. It doesn't matter if it's sexual exposure versus injection drug use. It doesn't matter if you're a transgendered individual, man, woman, or otherwise. This is our go-to answer for everyone just because it's the most well-studied. We've been using it the longest for this purpose. Descovy, you'll notice the number changed slightly on that from a 300 to a 25. Again, you need less of a tenofovir component to get into someone's body because more of it actually gets into the cells. So levels actually tend to be better where they're needed and less where they're not. It may be preferable to Truvada based on the toxicity profile, but typically speaking, we wouldn't switch someone just because. If Truvada is working and they're not having any toxicity, great, keep them on Truvada. It is preferred in people with some impairment of renal function because it's not renally as toxic as Truvada can be, and so less monitoring is required in some cases. It is approved for use only in biologic men, again, men or transgendered women greater than 35 kilograms. Not likely because it doesn't work in other people. I've seen it used plenty in other people, but we don't have the studies to back it up yet, and we tend to be very conservative about this sort of thing because we're talking about HIV. Intramuscular cabotegravir is the only long-acting injectable option. It has different pre-testing pre-use testing needs. More frequent follow-up is recommended for reasons we'll get into, and different counseling needs secondary to the tail, which we'll talk about a little bit. But again, this is our go-to answer. Truvada is the most well-studied, most approved. It's the answer unless there's a specific contraindication for it, and it's the answer in all groups of people. Alternative dosing with Truvada, we do have, it is not approved. This is very much an off-label use, but it is well studied. It is for biologic men who have sex with men only. And so that includes transgendered women. We need to have two things in place to use this alternative non-daily dosing. Sex needs to be fairly infrequent. Typically less than once weekly, and you have to be able to anticipate when you would be having sex, which is not always the case for a lot of people. Why do we need to be able to anticipate? We use 2-1-1 dosing. We use two pills of Truvada 24 hours before having sex, so we have it in our system already. Then we use one pill 24 hours after the first dose and one pill 24 hours after that second dose. There are some issues to navigate with this medication in particular. We're going to talk about some startup side effects. This can happen every time in people who are using it irregularly. When you're using these medications regularly, the side effects tend to go away. That might not be the case if you're using it sporadically, and you might accidentally out your patients by prescribing this for them. It is only approved for men who have sex with men. And if someone knows that about the medication and doesn't know that someone is a man who has sex with men, that might out them accidentally. So a consideration when prescribing this medication. What do we need to do to test before starting these medications? As stated before, PrEP is an incomplete HIV regimen. Typically, a complete regimen is 3 to 4 medications, very occasionally 2. And that's because HIV mutates very quickly. With 3 to 4 medications on board, if an individual virus were to mutate, it would simultaneously have to develop mutations to all of those medications at the same time, which is pretty unlikely. With these medications, we're using 1 to 2 medications. If we started that on someone who already had HIV, these medications, there would be a risk of those people developing resistance to those medications because it's only 1 or 2 medications, not the 3 to 4. So then they're left with HIV and less treatment options. So we really want to make sure before we start someone on it that we have HIV testing done and that they're negative. This can be done. You can start PrEP if you have point of care testing available in your office, as a lot of places do. But you want to make sure point of care testing is usually fairly accurate, but it can be a little less sensitive than your standard testing. And so if you're using that point of care testing to start someone on PrEP, you also want to make sure that you're getting the labs done. If you're going to use an oral regimen, to make sure that their kidney function is doing okay, and B, also to draw your standard HIV test. What else here? We also want to think about, I'll get back to that Hep B thing in a second. We want to make sure there's no signs of acute HIV. So we remember that very early in the course of HIV, testing may be negative. It takes a while because we test for the body's response to HIV. So if someone is acutely ill with a flu-like or mono-like symptoms, fevers, or new rash, it would be concerning for acute HIV, even with a negative test. And if they have these concerns, we should delay starting PrEP. If you can check a viral RNA if you wanted to at that point, because that would be positive because it's testing directly for the disease. Primary differences between the injectable regimen on the bottom there with cabotegravir and the oral regimens is you really don't need to check creatinine. You don't need to check kidney function in order to start the injectable regimen. Testing for hepatitis B. I would also suggest, though it is not in the guidelines to test for hepatitis B, the guidelines state that testing for hepatitis B should not hold up starting PrEP. However, tenofovir, which two of the regimens contain, treats hepatitis B as well. And if you don't know if they already had it, you could be suppressing them while you're on PrEP. And then when they stop PrEP, you can have flares of hepatitis B. Despite what the guidelines state, they also state that someone with hepatitis B should have their PrEP handled by someone comfortable with treating hepatitis B, which most people are not. I'm uncomfortable treating hepatitis B because the guidelines are really weird and it's a weird infection, which is why I would strongly suggest testing for someone for hepatitis B if they're not immunized before you start things up. Otherwise, you're going to be stuck with someone with a regimen that you potentially feel ill-equipped to stop. And this is also can be a great opportunity to test for other STIs and make sure that vaccines are up to date in our patients. What counseling do we need to give for PrEP? Adherence. Yeah, adherence is actually really important. Again, this is for men who have sex with men, but you can see that when we're getting, at least 4 pills a week of PrEP, the chances of acquiring HIV are basically negligible, but that falls pretty rapidly when we're not taking it regularly. And again, this is not fair. It's actually less forgiving in women. Women have to be more consistent with these medications for them to work. So adherence is actually really, really important to talk about. We also want to remember that PrEP does not prevent any other infection besides HIV. So we're going to still want to talk about safer sex practices, using barrier contraceptions, because we're not negating the risks of things like chlamydia and gonorrhea. Safer injection practices as well. We're not protecting people from hepatitis C by giving them PrEP. We're protecting them from HIV. Side effects, startup syndrome. Common ones are headache, nausea, and abdominal discomfort. This is not the bad old days of AZT puking and lactic acidosis and fatal rashes. This is kind of similar to like an antidepressant or metformin, though metformin can actually give you lactic acidosis, and none of these medications do. Typically, these go away over the first few weeks, can be up to a month. And again, if they're using the intermittent PrEP, it can be recurrent every time they start it. Again, this is not the bad old days. And then how long does this take to become effective? It's not exactly known, but generally in rectal tissue, it's around 1 week. Vaginal tissue, again, it doesn't get into the vaginal tissue nearly as well. So it tends to be about 3 weeks for women. Other considerations, the tail with Apretude. Because it's a really long-acting medication, when you stop, this prolonged period afterwards where you're slowly getting less and less of the medication in your system, and it's going to be subtherapeutic. It's not going to be protective in people. That's fine if you're no longer at risk for high risk for getting HIV. It'll just wash out and you don't need to do anything. The issue comes in if you remain at high risk, but now you don't have the protection of this. The risk there is that you could get HIV and it gains resistance to this medication because you just don't have enough of the medication in your system to protect you, but you have enough to expose the virus still. And so they recommend, if you're coming off of cabotegravir and you're still at high risk, that you transition to oral PrEP within 8 weeks, which is how long the medication is generally effective, or at least counsel about the risk of resistance if someone really no longer wants to be on PrEP. Prescribing PrEP. Again, PrEP can be done the same day if you have a rapid HIV test and you can get the blood work done. So if the blood work is going to soon be available, it's fine to start if you have that point of care test done. Typically with oral PrEP, we prescribe 90 days worth. I actually tend to prescribe 84 days because that's in an integer of 7, so it will end on the same day of the week as you started it, and you won't have to risk it running out on a weekend, what you do when you do a 90-day prescription, but you can do 90 days of oral PrEP. Typically, when you were doing 2-1-1 or intermittent dosing, we typically prescribe 30 pills of this. Prescribing PrEP on the same day. When would it not be appropriate to do that? It's basically if they're not sure they want to be on it, if we're not sure they're going to be able to adhere to it, if they're going to have difficulty getting a hold of it, or if logistics would interrupt their treatment. So those who have ambivalence about starting PrEP, if you can't get a lab draw, you can't start PrEP. If there's signs of symptoms of a possible acute HIV, You'd want to make sure it's not HIV before you start PrEP. If they have kidney disease and you can't start it without checking their kidneys. If they don't have insurance to pay for it or can't pay for it by other means, I would put out there. And if you don't have a mean to contact them, if they leave the office, they get their lab work done and you can't tell them what the results are. If they came back positive for HIV and you couldn't get a hold of them, that would be a bad thing. It may not be appropriate if they've had potential recent HIV exposure, even if they don't have signs or symptoms. You would want to really make sure that they don't have that. If they may not be contactable or if their mental health wouldn't allow them to follow up regularly or adhere regularly. Again, that may not be appropriate. We should be erring on the side of let's try to get people on PrEP if we think they have a chance of being successful with it. What about follow-up? With oral PrEP, it's every 3 months, consistent with the 90-day prescription. As I said before, typically do 84 days because that's going to fall on the same day of the week, so they're not going to run out on the weekends. Medications have about the same lab monitoring as diabetes or antihypertensive. Mostly, we're just acknowledging that people are at high risk for HIV and STIs, which is why they're being on treatment to begin with. So we're going to be testing for those things at 3 months, at 6 months, and 12 months. Then at 6 months for higher risk individuals, we want to make sure their kidneys are still working well. The CDC actually changed this. If you're younger than 50 and your initial testing when you started PrEP was good, you don't have to test your kidney function again for a year. So it's pretty low maintenance. And then you'll see at the bottom there, if you're on Descovy, there is some metabolic things we watch out for. We want to check for their weight and cholesterol levels at a year. For cabotegravir or injectable PrEP, primary reason we see people more frequently for this, you'll notice there's a lot of more follow-up visits. We have to load them up. So you give 1 dose at the beginning, 1 dose at 4 weeks, and then it's every 8 weeks after that. So we just tend to see people more frequently because of logistics. We're also a little bit nervous. ID people are uncomfortable with the idea of people only being on one medication, and we have less data around this one. So we want to make sure people aren't developing HIV, so we test them more frequently. We're essentially monitoring to make sure they don't have a breakthrough of HIV, which might actually be less likely with this regimen because of the easier adherence. And we want to, when we're talking to people and doing counseling, we want to remind them about that magic tail with cabotegravir. Couple of caveats. First, if you're using TDF, here's the table. Tells you exactly when to test for everything. With the Descovy there, we want to check that lipid panel yearly and a weight. Secondly, they say testing for hepatitis C only in these groups. I disagree with that. We know that generally speaking, injection drug use and vigorous anal activities are more likely to result in transmission of this. It's very well described among men who have sex with men. And vaginal and penile vaginal sex between a heterosexual couple is a very low risk activity for developing hepatitis C. But heterosexual couples might not only be having vaginal sex, so they're appropriate to be testing as well if they're at risk. So I actually disagree with the guidelines on this, but there's the guidelines for what they are. What about bone mineral density testing? Testing regularly for bone mineral density is not recommended for people on tenofovir-containing regimens for PrEP. What do we know? We know people with HIV on full treatment do develop osteoporosis earlier. HIV by itself is associated with earlier osteoporosis, and tenofovir, particularly the form found in Truvada, has been studied, and there are small losses of bone mineral density associated with this, but that's actually never been correlated with an increased risk of fracture. So no one's entirely sure with PrEP alone, but it's not likely to cause increased fractures. For high-risk individuals, it can be considered testing for bone mineral density, but usually we don't. And we can avoid this issue altogether by using Descovy if we wanted to, or cabotegravir for that matter. Follow-up for PrEP, again, with the cabotegravir, we're testing more frequently because we're anxious, and ID people are like that. We're worried that it's a single medication and it's less likely to offer complete protection, and we just have less experience again. Again, personal opinion, not guidelines here. Testing everyone that's at risk for hepatitis C seems appropriate to me. Big ol' asterisks on all of this. These are minimal testing intervals. If someone comes back in after the first months and said they just got back from an orgy with a bunch of strangers and no one was using protection, or they have symptoms, you absolutely test them between visits. This is a minimal testing based on overall epidemiologic risks in the absence of symptoms. So if they come in and they have risks, you test them. Also, we're reinforcing on follow-up for PrEP, our counseling, so adherence, safer practices, and the tail for cabotegravir, when to discontinue PrEP. Indications to stop. Patient doesn't want to be on it any longer. It's always the right to choose that, even if it doesn't make sense. If they remain at high risk for HIV, they have every right in the world to come off if they don't want to be on it. I tend to have them come back in 3 months anyway, because they're at higher risk and we'd be testing them for STIs anyway. And that provides another opportunity to talk about PrEP at that point in time if they remain at high risk, but it's their choice if they don't want to be on it. If they're no longer at high risk, they settle down, they live out in the burbs and get the 2 kids and dog, and they're not at any risk for HIV, cool. Don't be on a med you don't need. If they develop a contraindication, they have kidney disease, HIV, or an allergy to the medication, they shouldn't be on PrEP any longer. Or if patients cannot appropriately do follow-up labs or regular follow-up, we need to be able to prescribe this safely. There is a movement to offer PrEP over the counter, so it'll be interesting to see where that goes, because there is some things that need to be monitored, but we'll see. Things to remember when we discontinue, we got to remember that tail. I don't think I've said that enough times during the course of this, only 20,000. There's the tail with cabotegravir that we need to take into account. If they have hepatitis B, we have to remember if they are on one of the oral regimens that it could flare when we stop. So we need to do that. We document HIV status at the time of stopping to make sure they didn't have it or pick it up right near the end. We document why they discontinued and recent adherence. We document if they have ongoing risk factors, and we keep testing for HIV. And actually with cabotegravir, because of our anxiety around this situation, we keep testing them quarterly for a year after discontinuation to make sure they did not pick it up at some point while cabotegravir was not therapeutic in their system. So let's do a quick walk through here. First, we need to establish an indication. For sexual exposures, it's do you have sex, with who, their HIV status, do you use condoms, have you had an STI? For injection drug use, do you share injection equipment ever? That's it, we've established risk. Pre-prescription testing. If we're doing same day, we can do a point of care plus a blood draw. And that blood draw is to get a standard HIV test and creatinine level or renal functions for the oral regimens only. If we're having them come back, we could skip that first step and not do the point of care and just do the standard HIV and renal function for the oral regimens and have them come back. Counseling, we're going to talk to them about adherence. We're going to talk about safer sex and injection practices, potential side effects, time for it to become efficacious, and the tail if they're on cabotegravir. Monitoring, we have tables that tell us what to do. They're pretty straightforward. And that's it. That's the sum total of all we need to do to prescribe PrEP for people. Now we're going to do doctors are going to do some acting. We talked about doing like a case scenario and running through it, but the logistics of that are actually kind of a nightmare. So Dr. Sethi was kind enough to let me use her image. I hope I don't abuse it here. So the backstory on this one is I've fallen on some hard times and I go to see Dr. Sethi. Hey, Mr. Trowbridge, what brings you in today? Well, doctor, I have an abscess on my arm. I'm sorry to hear that. How did that happen? I think I got it from injecting. That sounds difficult. What have you been injecting? Well, mostly heroin. A buddy of mine was using it and it really helps my pain. Caveat here, this is a great time to step in with a lot of different conversations. If we weren't just talking about PrEP, we can talk about what practices we're doing to keep ourselves safe. Do you have naloxone available? Explore their beliefs around substance use, see if they want help with that. But for the purposes of this presentation, that's all the things Dr. Sethi would do. But we're not going to do that for today because we're just here to get PrEP. Tell me more, a great statement that you can always use in conversation. Well, I used an old reg, and I think that's why I got infected. It sounds like you know some things about keeping yourself safe, but you had to reuse equipment. Do you ever have to share equipment when you don't have new available? Mostly not, but sometimes when I can't get to the pharmacy, indication for PrEP over. Um, and that's often true with PrEP is people will either walk in as the reason for the visit is the indication for PrEP, or it comes out very easily in conversation and you don't actually need to dig that much. Um, I share injection equipment apparently, so indication for PrEP. Again, tell me more. I know I should use new equipment. I don't want to get AIDS or something. This is a great spot to talk about safer injection techniques and specific diseases if we wanted to go that route, but we're here for PrEP. Sounds like your health is really important to you. Did you know that there are medications available to make you less likely to get HIV from using? And again, this is another great spot to discuss treatment or discuss other preventative measures and testing. I did not know that. You said you don't want to end up with HIV. There are medications that you can take to prevent yourself from HIV if you're at risk, which you are right now. That sounds great, but are HIV meds super toxic? A lot of people think about HIV meds as being very toxic. Modern HIV meds are safe and often have few, if any, side effects. Don't I have to stop using or something like that? Absolutely not. Sometimes people aren't ready to quit. That doesn't mean we can't try to be safer. And if you want treatment in the future, talk to me about that too. What do I need to do? First, we want to make sure you don't have HIV, so we should test you. We'll also test some blood to make sure that you're safe to take these medications. Sounds good. I also want to talk to you about how it's important to take the medication as regularly as possible to make it as effective as possible. I can do that. Not a lot of people have side effects to these medications, but some people do. Most side effects are mild and go away in the first couple of weeks of taking the medication. Sounds good. It's also really important to continue to protect yourself with safer injection practices because PrEP does not protect against other infections you might get from injecting, like this abscess or hepatitis C. That makes sense. It's just for HIV. I can write a prescription and start you on medication today as long as we can get that blood work and we have a way to make sure we can contact you with your lab results. Perfect. Let's do it. I also want to see you again in 3 months to make sure we're testing you to keep you safe. If you ever want to talk about treatment options to stop using, I'm happy to have that conversation too. Thanks, Dr. Sethi. You're the best. It's really that easy. And it was kind of cheesy writing that all out, but it is really that simple. Like PrEP is about the easiest thing on the planet. Anyone can start it up. It's not complicated. Conversations can be really straightforward. And again, putting these in there, this is literally everything you need to know to do oral PrEP. All summarized in a beautiful slide. Here's the ones for cabotegravir if we're doing that. It's really straightforward. There's some additional resources. You can actually call a PrEP line to get help if you want to. There's also an HIV service locator that you can look where someone might offer PrEP near you. And I'm going to put a plug in for my local LGBTQ plus healthcare consortium. They are working on a toolkit right now, both for patients and providers to walk through the process of starting someone on PrEP. So good work for them.
All right, well, thank you, everyone. This was really great, and I hope it was helpful. This was so much information. Wow.